So, ma'am, shall we start, ma'am? Ma'am, we are starting, ma'am.
Yeah.
Yes, ma'am. So, yeah, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today's webinar is ovarian stimulation protocols. I would like to welcome all the participants for their active participation, and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. And now it's time to introduce our invited speaker for the day, Dr. Shital Punjabi ma'am. Madam is a gold medalist in MD and DGO and IVF specialist from USA. She has taken training for IVF and embryology from Cleveland Clinic, USA. And she has taken training for gynec cosmetic surgeries and has expertise in vaginal regeneration treatments. She has been a visiting faculty for national and international conferences in various countries like Bangladesh, Nepal, Sri Lanka, and almost all cities in India. Madam is practicing oncology since 1997 and founder director at Shashwat IVF Center since 2009 and founding director at IVF Department Motherwoods Hospital since 2012 and a consultant cosmetic gynecology expert at the Midhouse Touch Cosmetic Center, co-founder at MedGuru, a digital learning platform for learning education, treasurer GC ISR 2021-23. She is Gujarat President, Medical Cell Woman at International Women Rights Protection Bureau, Joint Organizing Secretary at Jain Doctor Federation, and active member of FOXY, IMA, Aspire, IMS, ISCR, IFS, and IAIMS. Madam has served more than 5,000 childless couples in their struggle for being a parent and conducted 5,000 plus deliveries. And with this introduction, I welcome you, ma'am. And ma'am, before going to section, I would like to take 1 minute of your time for sharing our Shield Connect web page, ma'am. I would like to share our Shield Connect web page. So this is our Shield Connect web page, ma'am, and this is a digital initiative of our Shield Healthcare. So you can find a lot of information related to women's health, which is available in our website, ma'am. And we have blogs, and our doctors are willing to share their research and thoughts and advice through blogs. So various blogs are available in our website, ma'am. And I request you also to share few blogs which can be available in our website, ma'am. And all our webinars are conducted through our Shield Connect web page, ma'am. So you can find the details of upcoming and past webinars which have been conducted in last 1 year is available in our website. And we have a small page for PCOS awareness also. You can find short videos of doctors explaining about PCOS in various regional languages is also available in our website. And this is our leaders page. So we have more than 230 to 240 key opinion leaders who are supporting our web page through their webinars and through their scientific contents in our web page. So thank you, ma'am, and I request the participants to go through our website and make useful of it. Thank you, ma'am, and over to you, ma'am.
Thank you very much, Dr. Stalin, and thank you very much, Shield Connect, for taking on this extraordinary initiative. And at the outset, let me pray for all our colleagues who have suffered from corona, who are passing through the treatment of the corona. So for their speedy recovery. And during this corona time, as we cannot do any offline conferences, such kind of use of the digital platform for continuous ongoing learning is really appreciable. So I really appreciate the Shield Connect for this program again. I'm going to share a few of my views regarding this program, this ovulation induction protocols. Let me try to get a PowerPoint presentation. Just give me a few seconds. I think I will take support of somebody who is technically advanced. Please bear with me. Thank you very much. Meanwhile, let me just start with yeah, just give me a few seconds. I'm trying to get this
Sure, ma'am. Sure, ma'am. No issues.
presentation. Take support of my daughter, Dr. Trishila. Yeah, please. Can you just take note of this?
Ma'am, you can close the screen, ma'am. You can close the screen, ma'am,
Okay.
and you can project it from your desktop, ma'am.
Try.
Madam, you can close the screen, ma'am. Yeah, ma'am. Now you can open it in your desk. Yes, ma'am. Yes, ma'am. It's okay, ma'am. Fine. Ma'am, you have to unmute, ma'am.
Yeah, thank you very much, doctor. So I'm sorry, this certain technical things we are not good at.
No issues,
Uh,
ma'am.
Thank you very much for bearing with me. I'm going to, talk about this ovarian stimulation protocol. And rather than going for academics, I would rather give some really good clinical tips for the practicing doctors. For gynecologists, those who are practicing the basic ovarian stimulation and infertility management, for those who are doing IUI, for those who are doing IVF, and maybe we can go for some clinical case discussions so that like do's and don'ts of stimulation protocol will be able to cover nicely. Now we all know that this is something which is really required for every single patient who visits our clinic in and day out for their fertility management. And everybody of us, we are aware that what to do. Most of the things which I'm going to talk about today is about what not to do, or maybe how to optimize the use of the different agents for ovarian stimulation. One thing. Second, when to stop going for just ovarian stimulation, when to start exploring the other aspects of assisted reproductive technologies, what to counsel our patients regarding the fertility treatment as a whole. And nowadays, everybody, all those who are like not even gynecologists, they also give certain ovulation induction agents to the patients. And many times they are not aware that if we are giving stimulation agents for some extended period of time, say for example, for prometheus cycling, we are giving for more than 6 cycles, then it is going to be harmful. It is not going to give result. The patient's money and everything is used, and patient is absolutely not getting any success. And her ovaries get exhausted. So it's very, very important to understand that when to stop. So any gynecologist, she, in my practice at least I know that from the periphery, the patient has come to the big center. He has taken more than 6, 7 cycles of clomiphene citrate, some 6, 10 cycles of letrozole. And the patient is not being treated properly, whether the fallopian tubes are normal or not, whether they are functioning or not. Most of the times I have seen that the patient's husband, he has not done his basic semen examination. And that lady keeps on gulping medications, taking some treatment. He feels that she would conceive. And like people have the couples have the male partner having azoospermia. So these things go on. So rather than talking about a lot of academics and a lot of protocols of IVF, like as I've been doing IVF since 15 years plus, like there is a learning curve of using the gonadotropies, and there are a lot to discuss in academics about role of HMG and role of FSH for induction and urinary HMG and purified and this and that and HCG and LH and step-up protocol, step-down protocol and normal responder. And then when to use gonadotropin, what particular gonadotropin, and when to use a GnRH agonist, when to use GnRH antagonist, and whether to go for like freeze all and how to prevent OHS. So many things we talk about. But today I'm going to talk about your basic physiology and basic pathology of ovulation, failure or dysfunction, and then we'll talk about that. There are no thumb rules. So in what particular group of patients, what would we offer? So it is not only about ovarian stimulation, not only about ovarian induction. It is about like as a whole treating a couple, making sure that the pregnancy. So is the chemical pregnancy like a patient gets positive urinary pregnancy test or positive beta HCG? Does that mean it's a pregnancy? No. Does that mean that there is early pregnancy and there is a good gestational sex scene and the yolk sac is seen, but sometimes there is no feature echo, sometimes it is blighted ovum, sometimes it is missed abortion. So do we call it a clinical pregnancy? It is a clinical pregnancy, but that is not what we want when we are treating our patient, not our patients want. So what do patients want? They want a full-term healthy baby. So beside any management protocol, we would rather think in the direction of what is hello baby rate. So there are so many research papers. When I was preparing this topic, I went through the latest ASHRAE guidelines and latest ACUG guidelines and recommendations for do's and don'ts. And whatever said and done, ultimately, what is most important is carry home baby rate. And that too, the mother is absolutely healthy, the baby is absolutely healthy, and there are, as far as possible, avoiding all the complications during the pregnancy, intrapartum, and postpartum. So we'll start with the ovum. When do we call ovulation induction? When do we call ovulation stimulation? When do we call ovulation augmentation? And how do we monitor it? Is it that we are just given certain medications to gulp and then, like finally patient comes with the pregnancy? No. When we are giving certain medications, we need to monitor its dynamic cycle. So we need to monitor the ovulation. So that is known as ovulation study. Now, if we are doing the ovulation study, if we are concentrating on the ovarian cycle, you must check the cycle as well. So that's what I'm going to talk. Like I'll throw a little light looking at the time. I'll try to cover all the clinical aspects of a gynecologist who may or may not be practicing IVF. When would we call ovulation induction, stimulation, or augmentation? For that, let us go to ovulatory dysfunction. So, physiology of ovulation first. Normal physiology, and then we'll go for what is deviation. And then in what particular group of patients we'll do ovulation induction, and what particular group of patients will go for ovulation augmentation. So we all are aware about two cell, two hormone theory. There are two cells, that is granulosa cells and theca cells. and two hormones, that is estrogen and progesterone. And for both the hormones, there is one whole pathway from cholesterol to either estrogen or progesterone, which pathway passes through androgen and pregnant women. So we all are aware, and if we understand this, then it is very, very easy for us to decide what treatment we should offer to our patient. As I told you earlier, there are no thumb rules. Second, I'm not going to go into different research papers. What I really want to target today is to go into the basic physiology of the hypothalamo pituitary ovarian axis. Then all those cells which are connected with ovulation, that is all autocrine and paracrine factors. Let us understand that. Then it would be individually customized ovarian stimulation protocol for all our patients. It's not that we just gave 50 milligram of clomivin citrate to all our patients. It's not that we gave letrozole 2.5 milligram or 5 milligram step up, step down, something like that to all our patients. No, they all are going to behave differently. Their ovary is going to behave differently. And the whole pathway, the pituitary ovarian axis, there is a positive and negative feedback mechanism. At hypothalamus is something which has two types of the factors working on the hypothalamus: intrinsic factors and extrinsic factors. Intrinsic factors are positive and negative feedback mechanism. External factors are stress, lifestyle, food, everything, like the depression and sleeplessness and everything. We know there is a role of melatonin and a hypothalamo pituitary function. So, for every single menstrual cycle, there is a different physiology. So it is again like, a single protocol doesn't fit to everybody. So let us understand the physiology. And if you will be able to understand the physiology, if we'll check the proper ovary at, during the first 3 days of the menstrual cycle, when we'll do a good follicle count, when we know what is serum AMH level, what is serum FSH level, then we will be able to customize for every single patient's age, the time of the infertility, previous treatment taken, patient's height and weight, that is her basal BMI, then her tubal status, both the tubes are patent or even single tube is patent, then about her partner, if husband semen parameters are normal or not. If we have checked all these things and we find out that yes, this is either poor responder or a normal responder or a hyper responder. Then again, this has good number of the follicle count, this patient has poor follicle count, and this patient has polycystic ovarian disease. So about the follicle count, why it is so important. So for that, let me talk about follicles, which are two types. One is gonadotropin independent follicles, and others are gonadotropin dependent follicles. Now, at the time of birth, when any female is born, when she is having her fetal life, we all know that there are multiple numbers of oocytes in the ovary. And they are in probably in the number of varying from 6 to 8 million oocytes when they are in the fetal phase. When a baby is delivered at the time of the birth, ovary is left with only 1 million of the oocytes. There are 10 lakh number of the oocytes. Now, ongoingly, there is apoptosis going on. And at the time of the puberty, female is left with 4 lakh of oocytes. Out of this 4 lakh, only 400 to 475 or 500, they are destined to ovulate during the whole of the reproductive years. So, the follicles before the puberty, they are all gonadotropin independent, first thing. Second, before the period cycle, before what we call last menstrual period, LMP, or day one of any cycle, minimum 300 days before this cycle, there is recruitment of around 300 follicles, which are destined to grow towards antral follicle. They are destined for growth and development, and 90% get degenerate by the time they are they are going through this phase of growth and development. By the time they reach the first day of the menstrual cycle, like for which they are recruited. So around approximately follicles, they are being recruited during the like exactly before the period that is the previous cycle's luteal phase, and these follicles they become gonadotropin dependent. So when we are treating the patient, we must know that whether why I'm addressing this, I'm going to talk about it, the clinical aspect later on. But when they are gonna in the phase of gonadotropin independence phase, that whatever amount of the gonadotropin we give to that patient, sometimes out of getting more number of the follicles, particularly when there are less number of the follicles, low level of the serum AMH and high level or borderline of FSH, it is our tendency to give extra dose of the HMG or FSH or recombinant FSH and in a high dose. So what happens? We are not aware that whatever amount of the gonadotropin we are pushing, the number of the follicles which have entered into gonadotropin dependent phase, they are only going to give a dominant follicle. Maybe like if you want a monofollicular growth, then a single follicle. But when we are going for ovarian hyperstimulation, then we want a multifollicular. So in poor responders, increasing the dose of HMG or FSH is not going to help us as far as the number of the follicles are concerned. So this is about the follicles which are gonadotropin dependent and independent. And here I would like to narrate one important point. In young patients and those who have low level of the AMH, but when we check the ovarian morphology with the ultrasonography, we see there are multiple small follicles, 1 to 2 millimeter or 3 millimeter in size. Clinical experience and by few of the research papers, though it is not being recommended, but few of clinicians and evidence-based science says that if these young patients and those ovaries are not damaged by any degenerative disease, then giving coenzyme Q10, melanotonin, and androgen in the form of DHEA that usually helps for this gonadotropin independent follicles to enter into gonadotropin dependent cycle, and there are chances that we may get good quality of the follicle which ovulates and then we may get pregnancy. We really need to wait for the research to endorse this statement, but clinically yes, I have seen in like many of my patients and many of my seniors and colleagues, they have been using these methods and they have been getting good results. So it comes to the recruitment of the follicles, then they become gonadotropin dependent. So now, in the two cell two hormone theory, there is the surge of the FSH, and that FSH increases the receptors on the granulosa cells. And then those granulosa cells they increase in the size and the numbers. The ovarian this follicle it produces the antral fluid from pre-antral follicle to antral and dominant follicle, and it produces the level of the estrogen, and the estrogen goes and works on the it has negative feedback mechanism, and then there is reducing the FSH, and then that with the reduced number of the FSH, the other follicles they regress, and only one or two follicles they tend to grow to be dominant. Now here there is FSH window. When there is good recruitment of the follicle, we have started with stimulation of the cycle. And if we see there are some 4, 5, 6 follicles, then we can increase the dose of the FSH if we are giving from injectable or in the form of we are inducing the FSH, intrinsic FSH by some oral medication. We can increase this the serum level of the FSH and we get a multifollicular growth. So here is the theory of the FSH window. Now with that there is a theory of LH ceiling, LH threshold and LH ceiling. So with the increase in the estrogen level in the serum, there is the feedback mechanism and LH secretion starts. A very low level of LH is required throughout the follicular phase. And at the time of when the follicle is mature, there is LH surge and that LH releases it creates the theca cells from the granulosa cells by the LH receptors. And then there is ovulation. And then during ovulation, what happens? There was the meiosis, which was arrested, and this LH, which is surged, that creates the environment. And because of this LH, there are two things which are happening. One is ovulation. Not only ovulation, the most important thing is arrest of the meiosis is it just goes away, and then that oocyte it enters into, it grows towards other phases, from prophase to other phases. So first meiosis arrest goes away and first polar body releases. So here comes the role of LH surge. Now, if somebody has chronically high LH, as in the patients of polycystic ovarian disease, then this LH induces the LH receptors on the granulosa cells. It results into premature aging of the oocyte. It results into atresia of the follicle. Now, if there is atresia of the follicle, there is no ovulation and there is no pregnancy. But what happens? And particularly we see all we clinicians, we say that in the patients of polycystic ovarian disease, there are very high chances of blighted ovum, of missed abortion, and the first trimester pregnancy loss. Why? Because of the and chronically high LH, at the time of the LH surge, normally then there is no PCOD, then LH surge happens when the follicle is mature. But when it is PCOD, then there is premature LH surge and there is like premature aging of the oocyte. And that oocyte is fertilized, then when that embryo cannot grow beyond certain age, that is first trimester pregnancy loss. So here in these patients, we get chemical pregnancy, we get clinical pregnancy. The pregnancy cannot go ahead as of midterm normal pregnancy. That's why we must understand the basic physiology of ovulation. Now with this, we have already covered this. Only one thing I would like to highlight over here is the androstenedione. When it is less than normal, there are paracrine fractures, and when there is a substance deficiency, these patients they do not get selection or recruitment of the cohort. And when there is very high level of the androgen in the antral fluid in the ovary, then it is resulting into polycystic ovarian disease. So this is about two cell, two hormone theory. Now, why we are understanding all this is so we want to prevent premature LH as in patients of PCOD, and when patients are hyperstimulated, then there are high chances that there will be premature LH. Second, we want to prevent OHSS because it is a very dreaded complication. All the IVF practitioners always worried about OHSS, and that's why almost all IVF practitioners have now adopted the protocols which are resulting into zero OHSS protocols. So for that matter, we have been using gonadotropin along with antagonist protocols. Then along with that, what we do is freeze all. And what we do is the cycle of the stimulation cycle, we do not go for LH surge using the injectable LH. What we do is we use antagonist and we use antagonist for the stimulation for prevention of LH surge and agonist for LH surge. Then do the pickup and freeze all embryos, and next cycle just prepare the endometrium and then go for post transfer, and which gives excellent results. So for prevention of HSS, third is prevention of multifocal pregnancy. When we do multifollicular ovarian stimulation or augmentation, either with the oral agents or with injectables, there are really very high chances of the multifocal pregnancy. And because of multifocal pregnancy, there are maternal mortality and morbidity, perinatal mortality and morbidity. We want to avoid that. We want to avoid congenital birth defects, and we want to have 100% pregnancy outcome. So for that matter, we understand the physiology of ovulation and then we go for either ovulation induction or ovulation stimulation or augmentation. Now let's talk about in this group of patients what do we do. There are two types of patients. There are anovulatory patients and there are ovulatory patients. In anovulatory, there are two groups, that is WHO type 1 and type 3. Not type 2, here there is a printing mistake. In type 1, it is hypo. I love these patients because when these patients have hypogonadotropic hypogonadism, maybe yes, here we have. So when they have hypothalamic failure, that is hypogonadotropic hypogonadism, like Coleman syndrome, Kehan syndrome, anorexia, something like that. So in those patients, most of the times, our estrogen level is low, FSH level may be low or normal, prolactin level usually is normal. In hypothalamic there is no pathology, and these patients, when we give, when we give extensive gonadotropin, HMG, these patients will give HMG only. The reason is they have hypogonadotrophic hypogonadism. So FSH and LH both are less than normal or maybe nearly zero. So when we induce their ovary with very high dose of HMG, we get a good response. Group 2 patients, they are pathetic. The polycystic ovarian disease patients, they fall into this category. And here it is the hypothalamic pituitary ovarian axis is intact, but it is dysfunctional. And they are very difficult to treat. Their estrogen level is usually normal, in a normal range. Their FSH level is in a normal range. Prolactin may be normal or high. In them, we see a very high level of the FSH, reversal of the FSH LH ratio, and they have like a lot of different clinical criteria as well. And we all are aware about Rotterdam criteria. Group 3 patients are patients who are hypergonadotropic hypogonadism. They are either premature ovarian failure or they are the patients of Turner syndrome or they are patients of autoimmune oophorytes. There are patients, mom's oophorytes patients, moms at the young age, if somebody has suffered from mom's oophorytes, then their ovaries are not responding to a high level of FSH. And in these patients, when we examine the biochemical markers, the FSH level is very, very high. Estrogen level is usually low or normal sometimes. And these patients are gonadal failure, and these patients, in a way, are like, very resistant because they're young age and they have like, streak ovaries or non-functioning ovaries, and we have to offer them donation site and they may not accept it. Menopause, this is the same condition, and like postmenopausal IVF is a very safe when the lady is medically fit for pregnancy and fertility. So we have like a lot of patients we are doing like either they are premature ovarian failure or streak ovaries or some genetic anomalies like Turner's or ovulatory failure or the postmenopausal. What we do is like endometrium is prepared and donor oocyte cycle is done with the fertilization of the oocyte with the husband sperms, and then doing embryo transfer. And in those patients, we have to just do preparation of the endometrium using the different criteria and using the estrogen and then supplements progesterone. One group of the patient who have like whom we have seen lately, those who have taken chemotherapy and those who have taken radiotherapy for different cancers, they have usually ovarian failure because ovarian cells are fast growing and fast dividing cells. So my advice to all my patients, I'm going to give the clinical tips as I told you, and with all the different factors in the WHO classification, I'm going to talk about my patient. So when any patient in the young age has suffered from any kind of the cancer in which either radiotherapy or chemotherapy or both is indicated, we advise our patients that you please go for ovarian stimulation, that is ovarian hyperstimulation, that is controlled ovarian hyperstimulation, doing this, that, and then doing pickup and then freezing the oocytes, then undergoing either radiotherapy or chemotherapy and this frozen oocytes can be used for IVF when the patient has completed with her treatment of radiotherapy or chemotherapy. Along with this, I would like to highlight nowadays the females are planning their pregnancy after the age of 35. So that time ovaries have exhausted the number of the follicles they have. So those females who have suffered from PCOS, suffer from endometriosis, they are advised that please don't plan your pregnancy later. But still, because of social or academic reason, or for career or for education, if they do want to plan their pregnancy before the age of 35, we advise them that when you are young, go for control ovarian hyperstimulation and do freezing of all sites, which they can use later on. So this was about the ovulation, selection, ovulation, induction, augmentation, or stimulation. So here, in all the patients of group 1, whatever we'll be doing, that would be known as ovulation induction, because here like, we are inducing even the recruitment of the follicle. So we are working on the 3 months on the gonadotropin independent phase, and then we are inducing the recruitment of the follicle by giving high dose of the gonadotropins when they enter into gonadotropin responding phase. So in this, we will be calling it ovulation induction. In group 2, we will be doing ovulation stimulation or augmentation. And in group 3, nothing can help those patients. So here we will be advising all those patients to go for donor oocyte. We all are aware about this FSH LH mechanism, and along with increase in the FSH, there is increase in the estradiol level, increase in the progesterone level when the LH surge is there, and slowly, after the 25 days of cycle, if there is no pregnancy, then FSH and LH both reduces, the serum level reduces so less that there is shedding of the endometrium, which is known as menstrual blood flow. We are all aware of this. So now let us start with what are the ovulation induction drugs. So these are the drugs which can be used in group 1 and group 2 patients. In group 1, clomiphene cyclate aromatase inhibitors are not going to help, because for that the hypothalamic pituitary ovarian axis should be intact. So in those patients where there is hypogonadotropic hypogonadism, the clomiphene cyclate and aromatase inhibitor, they are not going to help. In those patients, gonadotropins will help, that is HMG or FSH. There are other induction agents also like tamoxifen. Then there are multiple protocols, clomiphene cyclate plus gonadotropin, clomiphene cyclate plus antagonist, clomiphene cyclate plus melatonin, extended clomiphene cyclate protocol. And there is altogether different individualized, customized approach for ovulation induction in polycystic ovarian disease. In clomiphene also, there are multiple different variable protocols, and the dosage like varies from 50 milligram to 150 milligram depending on the pathology, age, and BMI of the patient. In letrozole also, aromatase group, I would rather say that AI group, it is like a step up, step down protocol, and it all depends, it is individual choice of a clinician, looking at the age and BMI of the patient and the pathology, of course. So now, how are we going to monitor? When we have done ovulation induction, we are going to, so when we are going for ovulation induction or stimulation, how would we select our patient? So that is by finding out the ovarian reserve. If ovarian reserve is good, the AMH level is normal. If AMH level is less than normal, then they are poor responders and they have like less number of the follicles. See, here it is very different from FSH. If FSH is very high, then it suggests that quality of the oocyte is going to be bad. But if FSH is normal and AMH is very low, then it is suggesting that there are less number of the follicles which are going to ovulate. This is important. And the enterofollicle count. So we have covered about AMH. And in polycystic ovarian disease, the AMH is very, very high. So it's like high responder. And here we have to be very careful in selection of the induction or stimulation agent so that we can avoid OHSs. The second thing comes is enterofollicle count during the periods. That is basal ovarian scan. In that, and we can find the enterofollicle in both the ovaries, whether they are centrally placed, peripherally placed, whether how is the stroma, how is the stromal blood flow, the number of the follicles which are between 2 to 9 millimeter size, we consider it as enteral follicle. And if the patient is going to be normal responder, we can probably, like, we can see some 5 to 10 enteral follicles in either of the ovary. And they are 2 millimeter to 9 millimeter in size. Now, if somebody has suffered from polycystic ovarian disease, then we see necklace and very big follicles are pushed to the periphery, and they're all going to be they're like they're seen as inactive follicles. But when we give them injectable gonadotropins, all this increases in size, and they produce a very high level of the estrogen, and that precipitates them to develop the OHS. So it is very, very important. So if we do not do secondary estrogen level, that's fine. In most of the patients, even if we don't do serum progesterone level on second day, that's fine. Even if we don't do the hormonal study all throughout the cycle, that's fine. But what we must do is a basal scan, find out AFC, basal scan to find out the protocol, like, if somebody has follicles in total in both ovaries, then yes, they are poor responder. They are not going to, it's not poor responder, but they have less number of the follicles. And we need to give them good dose for getting all the 4 follicles to be mature. Here is a difference between poor ovarian reserve and the patient who is going to be poor responder. Poor responder is a patient who was previously in a previous cycle, or is a history that she didn't respond to the normal dose of gonadotropin. She had not responded. Then it is poor responder. So after checking AMH and enteral follicle count, we should select. If the patient is young, if she is not going for IVF, and if either timed intercourse or IUI, if we are going to offer, and if the fallopian tubes are open and the semen examination is normal of her husband, then a good quality of the oral induction agent, and if required augmentation with the help of gonadotropin, is usually more than sufficient. If somebody has, like, grown up to certain size of the follicle, that is beyond 14 millimeter, and then there is atresia that is suggesting very high level of the LH. So these patients are stamped as polycystic ovary, and then they are treated that way. If the patient has ovulated for consecutive 3 cycles, clomiphene citrate or letrozole, then they are, and still if there is no pregnancy, then they are stamped as the clomiphene resistant patients, and we should add either gonadotropin or we should check for the other factors. Now, how do we monitor whether the given dose of the oral induction agent or injectable induction agent is appropriate or not, whether the patient is responding well, or whether she is going to ovulate, or whether she is going to pregnancy or not. So for that, previously a lot of biochemical like the blood tests were done, but nowadays we do not do that. Now with the help of the ultrasonography, a dynamic ovulation study is done. Number and size of the follicle is being measured if required. The color Doppler usually helps in finding out that how the follicle is growing. And along with the follicle, we must check for the endometrial receptivity also. So it is not only endometrial thickness, it is not only 3-line endometrium, it is not only the uterocervical length, but along with that, the color Doppler which suggests that, okay, there are the scores, the Applebaum scores, which suggest that how is the perfusion of the endometrium and what are the chances of implantation. And then there are pre-ovulatory signs in the follicle, where we see a halo, like usually in most of the patients we see halo, which is suggested that in a couple of hours it is going to ovulate. And we can, like, if we are going for timed intercourse, or if patient is given just oral induction agent, we avoid use of trigger injection. Earlier, like, it was considered that it is HCG only which can be given, but nowadays the recombinant LH is also available and can be given. And for those who are, like, going to develop OHSs, then HCG is avoided, and those patients are given GnRH agonist, either decapeptyl or glyburide, for induction of the ovulation. And in those patients, when we are giving the agonist as a trigger, then we have to give them a very good luteal phase support for prevention of the luteal phase defect, that is LPD. There are multiple different varieties of gonadotropins, either urinary or highly purified. The research papers, they are like, showing that there is nearly equal results as far as carry home baby rate is concerned. Whether to use highly purified HMG or FSH or recombinant, whether HMG or FSH, all these things, like, there are multiple papers. Some are pro this, some are pro that. Nothing is proven better than the other as far as the clinical data is concerned. I went through the latest 2019 guidelines, ASHRAE guidelines, and everywhere it is mentioned that whatever protocol you are using, um, if it is individualized and if we are getting good crop of the follicle, then the carry home baby rate is good, whether you have used highly purified or recombinant or urinary HMP or FSH. Only difference between urinary and recombinant is, like, we are sure that this is the amount we are giving to our patient, first thing. Second, we are sure of the purity, and impurities are being taken out when it is highly purified. Third, when the patient has chronically high LH, then we want to avoid excess LH in the form of HMG. So in those patients, the FSH has a better role theoretically, but research papers are not showing the advantage of one over the other. HCG versus recombinant LH, latest guidelines suggest that there is no advantage of recombinant LH over HCG. Role of low dose LH in recombinant FSH cycle, yes, it is proven. As it is proven, like as I have previously shared in two cell two hormone theory, that a very low dose of LH is required throughout the follicular phase of cycle. So for those patients, when we are giving recombinant FSH and the patient is down-regulated, and low dose of LH is going to help those patients. Antagonist protocol, favorite for all IVF centers as they are practicing no HSS clinic. So antagonist is the protocol. It is like, stimulation is done with the help of gonadotropins, urinary, purified, recombinant, anything in a proper dosage, no excess dosage, and the LH surge that is triggered, uh, we are giving with the agonist, and we are giving antagonist for the prevention of the premature LH surge. So we can prevent premature LH surge by two ways, either agonist protocol or antagonist protocol. In agonist protocol, the agonists are usually started in two ways, either short agonist protocol or flare up, or the luteal phase agonist protocol, that is long protocol. In that, the previous cycle, luteal phase and agonist is started, and patient is started with ovulation stimulation on the next periods, and that is second day of the cycle. Here in the patients, very high AMH, with PCOD morphology, and they have a definite signs of Rotterdam criteria for suffering from polycystic ovarian disease. These patients, we do not want to give agonist protocol as OHS's rate is very high. So usually the ovarian stimulation is started from the second day of the menstrual cycle, and after 5 days, again ovulation study is done. And once the follicle size is, nominal follicle size is more than 14 millimeter, antagonist is started along with the regular dose of the gonadotropins. There are two types of antagonists. One is daily given antagonist and one is fixed dose antagonist. Most of the times, the daily antagonist is something which is being preferred. And this is to prevent the premature LH surge. And when we have given antagonist protocol, the agonist is used for trigger. So this is about the role of gonadotropin. Color Doppler baseline RIPI studies to be done along with follicular study. You have to see the follicular growth, then pre-ovulatory indices, and at the time of the trigger, RIPI of the vessels. That is to be seen. This is shown in this. So if we see that more than threefold of the follicle, the follicular margin is having a good flow, that is suggestive that this is peri-ovulatory, and then trigger gives a good result. Along with the perifollicular RIPI and the blood flow, when we suspect the patient is going to be PCOD patient, or she is going to go for OHSS, well, systolic volume will give us idea when we do the baseline scan. that whether this patient is going for OHSS or not. We should do endometrial color Doppler, find out whether endometrial receptivity is there or not, and whether to proceed for the cycle or not. Now, for a normal natural cycle, just oral induction agent, even if you don't do color Doppler, there are pretty good chances. If you do color Doppler, it is good, but if color Doppler is not available, it is not going to do any harm. For IUI, to optimize the result, color Doppler helps. But for IVF, yes, for getting good result, if we take support of color Doppler, it actually helps in optimizing the results. Hormonal assessment and its interpretation. See, in a regular cycle, in normal oral augmentation agents, and in normal timed intercourse cycle, or in IUI cycle, usually all these things are not required. Day 2 estradiol, mid-cycle estradiol, pre-trigger estradiol, pre-trigger progesterone. It is required only when we suspect that the patient may be either poor responder or hyper responder. Normal responder, and in those patients whom we are not offering IVF, usually this is not required. In hyper responder, when there is excessive rise of the mid cycle estradiol level, then we can cost those follicles, we can reduce the amount of the gonadotropin, we can increase the length of the number of the days of the gonadotropin in a low dose, such that there is the maturation of the oocyte with a low dose of gonadotropin, and we can avoid the OHSS, that is ovarian hyperstimulation syndrome. So for mid-cycle E2 is required. For selection of the protocol, A2 estradiol is required for poor responders in some of the patients. Then we check pre-trigger estradiol, that is in patients of IVF, and then they are hyper responders. If the estradiol level is very high, then sometimes we have to completely avoid giving the trigger in any form for avoiding the OSS. But nowadays, because of use of antagonist, usually that dreaded complication never arises, and we can just give a very low dose of agonist, and then, we can just give some 1500 dose of the HCG or recombinant LH, either 125 or 250, and we can, pick out all the sites doing the pickup, and then we can freeze all, and then we can avoid OHSS. So, primarily, like in OHS, there are two varieties, primary and secondary. In primary, it is due to HCG and the LH, which is used in trigger that results into OHSS. And secondary is once there is implantation of the pregnancy, and the pregnancy starts producing beta HCG, and that results into OHSS. So that's one. Pre-trigger P4, very important for those patients where we have tonically high LH, and then we expect that this endometrium has exposure to unnecessary amount of the progesterone, and this endometrium is not going to be receptive, or that endometrial receptivity window, whether it is open or not, that time pre-trigger P4 gives us idea. For me, in my clinic, the cutoff is 1.5. If the P4 is higher than that, then we suggest you of like not going to get a very good implantation, and we go for freezing, and then we transfer, we go for FET cycle. So here, very important is site morphology for all IVF patients. But as I'm not going to discuss about the lot of embryology, as like in my introduction, Dr. Stalin introduced me as someone who has done IVF and clinical embryology from Cleveland Clinic, USA. I have been checking on ovarian morphology of all my patients. And if the morphology is not appropriate, then we may not get good fertilization with IVF, and that is fertilization failure. And that we may not get good quality of the embryo, and we may not get a clinical pregnancy. So that's why we check the outside morphology. And I have seen that in the patients of PCOS and endometriosis, and those who are aging, they are 35 years plus age, they have a poor quality of the oocyte morphology, and then here we do not get the good result. So this is the normal quality of the oocyte, and they are like these are different poor qualities of the morphology, but I'm not going to go into detail about that. This is the subject of the embryologist. But yes, this is very, very, very important when we do IVF for HC, because this is going to decide the fate of this oocyte, whether it will be converted into embryo or not, and whether they will be giving us a good normal top quality of embryo or not. And that will decide whether there will be pregnancy or not. So, oocyte may be post mature, hyperpigmented, there will be zona, particularly those who have 35 plus age and those who have suffered from endometriosis. Post-mature oocytes usually when we have like waited more than enough for the giving for the trigger, and then in those patients we get post-mature and hyperpigmented oocytes, and here we cannot expect a good number of the pregnancies. So that's why it is important. So why we are talking about all these things? Because it is the oocyte quality. It is oocyte. What is there in the ooplasm? How is the genetic material of the oocyte is going to give us the result, and that's why we must understand the normal oocyte morphology. Morphology is disturbed. There is disturbed quality of the oocyte, disturbed pathology. There is a disturbance in the oocyte function, particularly in case of ovarian disease. When there are low ovarian reserve, that is aged ovary, and those who have suffered from endometriosis. So that's why it is important to say. Low ovarian reserve, as I was talking, that we can do something in low ovarian reserve. If the ovary has not suffered from any degenerative disease, then maybe in the 3 months prior to ovulatory cycle, if we supplement female with DHES, then with CoQ, that is coenzyme Q10, myoinositol B12, it might help in few of the patient, but we need more clinical trials to stamp it. But we can definitely try in young patients who have poor ovarian reserve. If the ovarian blood flow is good, or if ovaries are not shrunk, absolutely strict ovaries are not there. If FSH level is borderline and if AMH level is low, then we can try this out. So, and now one more thing, that is oxidative stress. There is a definite role of oxidative stress in poor quality of the oocytes and poor pregnancy outcome. So for that, there is a definite role of antioxidants as add-on therapy or co-therapy along with ovulation inducing agents, either oral or injectable gonadotropin. So I hope that I have talked about the basic points of the tips and tricks, do's and don'ts of ovarian stimulation. We may keep on talking about different protocols of stimulation, individualized protocol, what level of FSH, what to do, what number of the interfollicle count, what to do, how to step up in the patients of ovarian stimulation for IVF and ICSI. In poor responders, how to step down, what level of estradiol we should go for each particular molecule for the trigger, when to do freeze, when we do freezing, how will we prepare the endometrium for the FPT cycle. When we are doing donor oocyte cycle, how do we prepare endometrium using what kind of the estrogen and progesterone, and for how long shall we continue with that? What shall we do for post-menopausal pregnancy? And so on and so forth. But looking at the time constraint, first thing, and second, because I wanted to throw light on individual protocol. So rather than about the protocols, how about understanding the basic thing about what is required by particular ovary in particular cycle? I have tried to give the justice to this topic with that basic and applied clinical knowledge, which has a lot of eminence in whatever I have spoken. As I have delivered around 3,000 plus IVF babies, whatever has been successful clinical applications, I have tried to cover everything in this 1 hour of time. I really appreciate one more time the Shield Healthcare, and I appreciate Dr. Stalin to reach out to me for this topic and giving me the opportunity. I am thankful to all the delegates who have spared their time for this talk today, and I'm sure by this all our patients are going to be benefited by this talk. And I really wish that it should propagate to all our patients, and all our patients should be happy. When I was in Bangladesh, when I was talking about this topic about fertility management, somebody asked me the question that we all Asian countries, South Asian countries, and India, Pakistan, Bangladesh, we have the problem of huge explosion of the people, and we really need to do go for family planning. There is use of contraception. Then why shall we help our patients for fertility treatment? So my answer to them was that as a whole, as a India, like as a public health, we see there is explosion, in the population. But how about that single woman who wants to be a mother and she is not able to conceive, and there is a huge social stigma, and she is not being accepted as a normal human being in the society. And what is the experience she is left with? And for that, we all fertility experts are committed to complete their family, to create the miracles in their life, and to partner in their success, to live extraordinary, complete life. And for that, we all are working this hard. And I really appreciate all gynecologists out there who are committed for their patients and their happiness. Thank you very much.
Thank you, ma'am.
Dr. Stalin, I will
Yeah,
stop
ma'am.
here.
Yes, ma'am. Thank you. Thank you very much for that detailed presentation, ma'am. It's always a honor to hear you, ma'am. Ma'am, on the outset, I would like to first thank you for accepting our invitation and for being with us today. I know that, ma'am, there was some cyclone, and there was a lot of issues running around you. But even then, you spent time with us today, ma'am. And ma'am, if there is any questions in the chat box, I will read out for you, ma'am. Let me wait for 1 or 2 minutes for the participants to post their questions, ma'am.
Yeah, sure.
Yeah, ma'am. Ma'am, we have one question like in ovulation induction with clomiphene citrate, will you recommend HCG injection for egg release? If so, what is the recommended dose and timing for in the cycle, ma'am?
Yeah. So when we are using clomiphene citrate for ovulation induction, if the patient is having polycystic ovarian disease, then we should be watchful in ovulation study for prevention of the premature atresia. First. Second, we must give the injectable HCG for ovulation trigger. If the patient's BMI is normal, and if she is not extremely overweight or obese, then 5,000 units of SCG suffices. And my request to everybody is we must make sure that she has ovulated. Because once we have given HCG and if we consider that she has ovulated, it is outdated concept. We must make sure that she is ovulated after 36 hours of injectable HCG. Once we check and if she is not ovulated, we can give another dose of HCG to that patient. So that is about HCG. After egg release, in clomiphene-induced cycle, we must give some good form of progesterone support for luteal phase defect. Because the patients who are given clomiphene citrate, there are all chances that her luteal phase is defect. So this is my take on for clomiphene citrate.
Okay, ma'am. Thank you, ma'am. Ma'am, what will be your preference, ma'am, for ovulation induction, clomiphene citrate or letrozole, ma'am? And what about the live birth rate with both clomiphene citrate and letrozole, ma'am?
See, both the molecules are good. Clomiphene citrate works on a different way, and letrozole works in a different way. Letrozole has a central action, and it works on the aromatase, and it works as aromatase inhibitor, and there is a monofollicular growth. Clomiphene has its own pros and cons, and clomiphene is always a first line of treatment in all the research papers. Now, in my patients, when the patient has polycystic ovarian disease, when she has hypothyroidism, when she has hyperprolactinemia, when she has this thing like insulin resistance, then my preference is use of letrozole rather than clomiphene. If the patient responds very good to letrozole, then no problem. Otherwise, we can even combine clomiphene citrate plus letrozole. Advantage of letrozole over clomiphene citrate is it gives monofollicular, so it's two follicles. While in case of polycystic ovary, if you use clomiphene citrate, most of the times we have to use clomiphene citrate for those ovulatory dysfunction patients. In those patients, when we use clomiphene citrate, there are multiple small follicles, but like not a single follicle we'll get as a dominant follicle, And that time we have resistant in the air clomiphene resistant patient. So this is one thing. And in those patients, I advise the patient to use either metformin or some other insulin sensitizer. My favorite molecule is metformin. Metformin plus clomiphene citrate usually gives us result. And in that, we check for the pre-ovulatory sign, which was earlier asked, that we see one halo in the dominant follicle. It is regular, a round follicle with around 18 to 23 millimeter in size, a very nice, sharp, regular border of the follicle with a very good perifollicular blood flow and very good triple line endometrium, which is approximately 8 millimeter plus and not a hyperplastic endometrium, that is, which has not crossed the 12 millimeter of endometrium, and with a very good endometrial blood flow. In the endometrial itself, in the three line, this is a good flow. So that is the sign like when I'll be either it is clomiphene citrate or letrozole cycle, I would be giving the injectable HCG. Regarding the carry home baby rate, yes, in case of polycystic ovarian disease, if we have like induced the ovulation with letrozole, we have a better advantage as far as the pregnancy is concerned and the carry home baby rate is concerned. Because as I had told earlier, that in clomiphene cycles, there are chances that there is a little high level of LH throughout, and that results into premature aging of the oocytes, and many times that results into either blighted ovum or missed ovum. So we have to everything. So for me, my experience is good with use of letrozole in all polycystic ovarian patients. Hope I have answered this question.
Yes, ma'am. So, ma'am, what will be the ideal IVF protocol for a woman who is having menopausal symptoms, ma'am?
See, in that there is first of all there is no ideal protocol. Second, there is no thumb rule. Third, one size doesn't fit all. Fourth, we have to check the serum AMH level. We have to check follicle count. If somebody has already perimenopausal symptom, then we must check the follicle and AMH. If AMH is very, very low, then there are very gloomy chances that somebody would respond to any dose of gonadotropin. So here we need to counsel the patient properly. There was a time when people used to give 600 units of HMG, but the trials have proven that more than 300 of HMV doesn't give a good number of the follicle. So here, the ideal protocol is if AMH is okay, like around 1 or so, if it's a good number of the follicles, that is around minimum 4, if less than 4 are entry follicle, then we should not go for stimulation or cycle. If a good blood flow is there, then we can start with 300 units of HMG, and we can like definitely monitor the cycle. We can increase the dose if required, but usually it is not required, and we can take care of the serum estradiol level to find out that at the time of the trigger, minimum 150 to 200 of serum estradiol level is achieved, and then if we give trigger, then we get the good quality of the oocyte, because ultimately it is the quality of the oocyte which is going to give us the result. So more than 300 units, not at all recommended. Maybe we can give long cycle. That is like if somebody is responding in 9 days or 12 days, then we may go for 14, 15 days of stimulation. And in that we get a good cycle. Even if we get a good two M2 oocytes, we get a good result. So it is the quality of the oocyte which is more important. Take home is less than 0.5 mH, don't go for stimulation. More than 12 FSH, don't go for stimulation. Less than 4 AFC, don't go for stimulation. Counsel the patient. We may need the donor oocytes later on. If still patient wants that, no, I want my own biological child, then we can do a full cycle. That is stimulate the cycle with 300 units, take out the oocyte, do home pickup, take out the oocyte, freeze that oocyte, then don't do transfer. The stimulation cycle helps in these patients. Immediately after pickup, start the stimulation, again stimulate, and then do the pickup, take out those sites 1 or 2, and then freeze them. Again go for third cycle, pick out 1 or 2 sites. Now we have some 6 to 8 sites. Or maybe we can make embryos and we can freeze them. Usually, like my clinical experiences, the frozen embryos gives me better results. So what I will do is do make embryo, freeze it up, see, freeze it. Then I'll go for FET cycle. So then,
Okay,
there are very good chances of
yes,
pregnancy. So here, I think I have answered this question.
yes, ma'am. Ma'am, and we have one last question, ma'am. Like, what should be the ideal dose of FSH to start with in luteal support, ma'am?
So, luteal support, we never require FSH.
Okay.
Yeah, in luteal support, the molecule which is proven in all the ways, clinically and in academics and in research papers, it is the natural micronized progesterone which is helpful. And second is dydrogesterone, which has a definite role. So the progesterone, and progesterone, it is helpful in luteal support. We never require FSH for the luteal support.
Okay, ma'am. Ma'am, I don't find any other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
So if anybody is having any question, you can reach out to me
Yeah, ma'am. Sure, ma'am.
on my like all social media pages I have by name Dr.Shital or by name Sashwat IVF, like in all social media. And I'll be more than happy that we can discuss out, we can exchange our experiences of treating our patients, something which works in one group of patients and may not work for other group of patients. So I'm more than happy to have a discussion with my colleagues there, So my number, I think Dr. Stalin, you would like to share. Here I would share, it is 74340 on this number, I am reachable on WhatsApp, and we can definitely share our experiences. And like, I would like to have more knowledge about the subject with all my colleagues there, like attending this webinar. Thank you very much.
Sure, ma'am. Sure, ma'am. That I will do that, ma'am. So thank you once again, ma'am. I would like to thank all the participants for their active participation and patient listening, ma'am. I would like to thank one and all on behalf of Shield Healthcare for joining the today's webinar. Thank you, one and all.
Thank you very much.
Thank you, ma'am.
I'll be leaving now.